hand raised until Cynthia acknowledges that she's recorded the vote, and the recording has just been turned on for this meeting. So I think we should be all set. Nina, if you can go off camera now, and we'll tell you when it's time to speak in public comment, and then you can come back on camera. Ninfa, thank you. All right, so I think, let's see, who am I missing? I'm only seeing 4, 5. Okay, we're all here. All right, Kat, you may take over, please.
Sure. Can y'all hear me okay?
Yes.
Yes. Okay, great. I'll still try to work on my headset here. I think I'm on speaker right now, so I'll work on that in the interim. So I'm going to call the meeting to order. And first, I'm seeking approval of our minutes from September 15th that were sent out previously.
You need a motion? I'll motion to approve the minute.
Yeah. And a second?
Second.
Okay. All in favor? Raise your hand or do your reaction.
Ken, did you have your hand up?
People, so.
Okay, I got everybody. Thank you.
All right, thanks. So now we'll turn it over to Bradley for the 2026 approved rates.
Hi, thank you. Thanks for having me here today. I'm Brad Bobin, the Chief Actuary at the MIA, presenting on the 2026 individual and small group market rates. Next slide, please. It's just a background about our rate review process. Maryland insurance article requires that all rates cannot be excessive, inadequate, or unfairly discriminatory, and they must be reasonable in relationship to benefits. And so those are the standards that we use when reviewing our rates. If we find the rates are not reasonable in relation to benefits or excessive or inadequate, the commissioner can disapprove or modify the rates. We begin our rate filing process by reviewing 2024 experience for the 2026 rates. So there's always a 2-year gap between the experience period and the projection period. In general, when we review carriers' assumptions, we're reviewing all the assumptions both individually and in aggregate as required by the actuarial standards of practice. So we're trying to make sure that everything is reasonable on both levels. Key assumptions for the 2026 filings include claims trend, both cost and utilization across different service categories. It includes morbidity, the relative health status of the pool, operating expenses, profit margins, risk adjustment transfers, reinsurance recoveries, and finally the impact of proposed federal legislation and regulations, especially the expiration of the enhanced APTCs, were some of the major assumptions that we had to review during this filing process. Next slide, please. So this is the timeline. This is, we initially got rates on May 19th. We had a public hearing in July. Then the MHBE board voted on a state subsidy in August, and that state subsidy caused us to have carriers refile and file lower rates based on a better morbidity under the state subsidy scenario than under no subsidies at all. And finally, we approved rates on September 19th. So that was a little too late to present at the last board meeting. So that's why I'm here now instead of last month. Next slide, please. So some of the key market trends is that, the rates remain affordable. Marylanders have some of the lowest rates in the country right now. The bottom 5 on all metal levels, the absolute cheapest bronze plan, and that's projected to stay the same. That we're still going to be amongst the handful of lowest rates in the states, of lowest unsubsidized rates. And as one metric of how low those rates are, our approved 2026 rates are still 6% lower than the 2018 rates, which was before our 1332 waiver. So this just speaks to the effectiveness of that 1332 waiver and how important it is. 2026 is 8 years after 2018, and yet the rates are still 6% lower. So I think that's a real testament to the reinsurance program. There is a 13.4% increase being approved, and that's driven mainly by the expiration of the federal tax credits and the worsening morbidity that results from that, as well as high pharmaceutical trends. And then, we know that the majority of Marylanders do not pay full price. They don't pay the unsubsidized rates. 78% of people who purchase on the individual Maryland Health Connection are getting APTCs. Right now, enhanced APTCs are in effect through the end of 2025, but they're set to expire unless Congress takes imminent action. Next slide, please. And so, as the state subsidy program was created and voted on in the last board meeting, and it's in effect for 2026 and 2027. And the subsidy program is going to replace 100% of the enhanced federal subsidy for those up to 200% FPL. It's going to phase from 100% replacement down to 50% replacement between 200 and 250% FPL. And it's going to replace 50% of the enhanced federal subsidies for those between 250% and 400% of the federal poverty level. Those earning more than 400% of the federal poverty level will not be eligible for the state subsidies, though. Next slide, please. So as I mentioned, carriers were approved for an average increase of 13.4%. That ranges from 9.8% to 15.2% by carrier. If the ARPA subsidies are to be extended, it would be estimated that the average rate increase would come in from 10 to 11%. This is higher than the initial filing of 7.9% back in May due to the change in the reinsurance attachment point, and also due to higher trends set by the HSCRC. Aetna is unfortunately exiting the market, the individual market nationwide, not just in Maryland. But this is going to impact just under 5,000 members. And they're going to be mapped to another carrier. In general, the carriers are seeing a pricing trend of 6.4% in the individual market. This can be broken down between 4.8% on the hospital trend, 6.1% on the professional physician trend, and 10.4% on the prescription drug trend. So as I said, that double-digit prescription drug trend is a big driver of the overall trend, and it is contributing to the higher increase. But the main driver is definitely the morbidity. With enrollment expected to fall 16%, carriers are projecting the healthier members are going to be more likely to lapse than the sicker members, and it's going to worsen the risk pool by approximately 12% according to carrier projections. Next slide, please. So the enhanced subsidies, the enhanced premium tax credits were originally passed in 2021 during the COVID pandemic. They both increased the amount of subsidy for everybody already receiving a tax credit, and it also removed the 400% cliff and allowed tax credits to any income where the benchmark plan would be more than 8.5% of income. Since May 2021, when those tax credits were first enhanced, there's been more than a 50% increase in those receiving the tax credits. It's gone from 126,000 to 190,000. And right now, the status of that, the enhanced APTC is still uncertain. It's before Congress. It's a big sticking point in the shutdown, and whether or not anything's going to be passed is still uncertain. Next slide, please. So if the APTC subsidies are extended, the rates are expected to decrease further from what was approved. I said on the other slide, we would expect between 10 and 11% if the carriers were to refile lower rates for the enhanced APTC. If the enhanced APTC subsidies are extended, with a clean extension, then the state subsidy program will sunset and they'll just be the federal subsidies. And if the rates are not extended imminently, it could be too late to have the carrier refile rates. We're definitely already at a date where things would be very messy to change rates. And if things are not passed soon, it might be impossible to change the rates. Next slide, please. So this slide's a little hard to read. I apologize for that. But this shows the amount of increase for a hypothetical individual age 40 at different FPLs. The top left section, the top section shows an individual, the bottom section shows a family of 4. On the left hand of the page is what's going to happen with the state subsidy. So, you know, at the lowest FPLs, 200% and lower, there's not going to be any increase because of the state subsidy. And that compares to the right, that shows the federal increase, where the increase would be measured in the thousands of percents if we had not put the state subsidy in. You know, and as far as dollar amounts go, you know, you can see at 138% FPL, just barely too high to have Medicaid. Right now they're paying $1. They're going to pay $1 with the state subsidy, but under the new federal subsidy, they're going to go up to $57 a month. So, you know, that's a huge percentage increase, obviously, but it's a pretty large dollar amount increase for someone who is, you know, barely earning more than Medicaid. Then as you go down the FPLs, you can see that at 250% FPL, there is a 55% increase. And you know, that's relatively hefty, but that's half of what it would be if the federal subsidies with no state subsidy and with just the federal subsidies. And so, you know, the same story happens with the families. You know, there's 0% increases for the lower incomes where we're subsidizing 100%. And then, you know, there are, you know, sizable increases, but much lower than they would have been otherwise for the higher FPLs. Next slide, please. So this just goes through what I just talked about. A single person making $31,300 a year, 200% FPL, is going to pay 0% more thanks to the Maryland premium subsidy. And if they had not implemented the subsidy, the same individual would pay 227% more. Next slide. For a family of 4 that makes $80,000, there's going to be a 55% increase. Like I said, that was, you know, on the previous slide, this is at 250% FPL. If Maryland did not have the state subsidy, they would pay 110% increase. So, you know, it's a lot better under the state subsidy, but still a significant increase. And then finally, a family of 4 in Maryland that makes $128,000 can anticipate paying $1,427 per month in coverage versus $916 in 2025, which is a 56% increase. And this is a family that's at 401% of the federal poverty level. So they're just above that cliff. So right now in 2025, they are getting subsidies, but they'll be paying full price in 2026. Next slide, please. So this shows a summary of the increases for the unsubsidized rates for 2026 by carrier. You can see in the final column on the right is what's been approved, a 13.4% average. The lowest is Kaiser at 9.8%. The highest is United Optimum Choice at 15.2%. But you can see how that compares to the column to the left, 17.1. That's what was originally filed. So you know, the decrease is thanks to the state subsidy program primarily. And then the other thing just wanted to point out is that enrollment is, you know, at a record level, 294,000 as of July 30th, 2025, July 31st. That's 8.6 higher than last year. But we do expect the trend to reverse next year and for us to start losing enrollment. based on these increases. Next slide, please. So for individual dental, carriers had a rate decrease approved, an average decrease of minus 1.4%. Approximately 51% of dental policyholders will be receiving a decrease. And claims trend in dental remain very low compared to medical. They're running a little under 3% on average versus the 6.4% in medical. Next slide, please. And this shows what's been filed by dental carrier. You can see originally they filed a minus 1.3% average increase. The one carrier that increased rates, Dominion Dental, we pushed them down from 2.2% to a 1% increase. And so that's what lowered the market-wide average to minus 1.4. And dental rates in general have been flat or slightly decreasing for several years now. And dental enrollment continues to grow. It's up to 100,000 enrollees. That's over a third of the individual market is selecting dental along with their medical. Next slide, please. So the small group ACA carriers originally filed a 5.5% increase, and they were approved at a final rate of 4.9% increase. It varies by carrier, but the carriers range from 2.9% to 11.8%. And major driver rate increase is in the individual market is definitely trend, particularly prescription drug trend. Prescription drug trend in the individual market was 10.4%. In the small group market, it's running at 12%. Even though the average trend is 6.9%, we were only approving a 4.9% trend, and that's mainly because of favorable experience in 2024 with claims coming in lower than expected. So they started the experience period in a favorable positive position. So that's why they need less than a trend level increase. And then we did see a 10% enrollment loss in small group. This is concerning to us, and we continue to monitor it. But the one good thing is that the morbidity of the market is stable. We're not seeing that effect that we're fearing in small group, where it's healthier small groups that are lapsing. So we're not seeing an increase in the morbidity, but we are seeing a decrease in the enrollment. Next slide, please. So this shows the average increase by carrier. Also apologize, this is a little hard to read, but you can see in the far right that 2.9% is what the lowest increase is by CareFirst Blue Choice. That's about 71% of the market is getting that 2.9% average increase. And then you can see the highest increase is the CareFirst PPO getting the 11.8%. But the average across all carriers is 4.9%. And then you can also see that 10% enrollment decline we talked about. Next slide, please. All right, at this point, I'll take any questions.
And before questions come in, I want to thank Brad because he's on vacation, and he came to present again this month because we weren't able to do it last month. But thank you, Brad, so much for giving of your time to come to the board meeting today.
No problem.
Great presentation.
Joanne, I see you have a.
Yeah. Thank you, Brad. This is super helpful, especially knowing you're on vacation. So a couple of things. The prescription drug trend, did anyone mention a role for tariffs? Sometimes that's come up, I know, in prescription drugs especially, or the cost may be affected by tariffs, or maybe it's just utilization.
Originally, one of the carriers did try to file an increase on drug due to tariffs, but we had them remove that because the tariffs have not materialized yet. There's still a risk that there could be tariffs in the future, but no, right now these drug pharmacy trends are high without the added impact of tariffs.
Well, I'm glad you're keeping track of where we are with the chart. I have lost track. Okay, thank you. And then, so just so I'm clear, they filed 2 rates, one with the extended enhanced premium tax credits, one without, and then they modified the without to incorporate the state subsidy. So what's still sort of waiting in the wings is, should the enhanced PTCs be extended at the federal level, then that slots through and there'll be a further reduction in rates. Should that happen soon enough to be reflected in the rates? Is that the idea? The one that's sort of the second filing out there is with state subsidy, but without the federal enhanced subsidy, right?
So maybe I can jump in here, Brad, because we're literally living this and waiting, Joanne.
Yeah, I know.
So I think if we get enhanced APTCs, let's say before November 1st, I think we would ask our carriers to refile the rates with updated morbidity. There was also the change in the reinsurance program that impacted rate filings as well. But yeah, so we would ask them to do that. I think if we get past November 1st, and I think Michelle, we're all gonna have to stay in touch about what happens if we get an extension after November 1st.
Yeah. Are we thinking about that yet? I mean, it's looking pretty grim, but should that happen, have we, and Michelle, this might be something for later in the meeting, just, what are the pieces that get revisited? The state subsidy, I guess, for sure, but also potentially how people are credited, or outreach or anything. Is there sort of a plan in place? I know there's
Yes, yeah,
incredible
well,
federal
there
uncertainty
is.
that makes everyone's jobs complicated, but I'm just wondering if there's
Right.
any sense of anything right now.
As Commissioner Grant said, we are moving, on an hour by hour basis.
Mhm.
But other options, and I'll go through some of these when I do the executive update, but there are other options that we can explore. And it will just mean, how much time we have, what will be the best impact for consumers and with minimal disruption of other efforts ongoing. So let me hold that for my update because I have more
Yeah.
there.
Let me just thank you, though. I know you've done everything in your power to make people aware that this is not a December 31st issue. This is a now. So I really appreciate your efforts to make that clear to the stakeholders in Congress.
If there are no other comments, then I guess we will move on to the next item on the agenda. Did we have anybody register for a public comment period?
We do. Lady Garcia, I'm not sure if she's online. I have not seen her, but
She is online. I have seen.
okay, good. Okay.
And just a reminder, if you're not speaking or presenting, please turn your cameras off. That would be helpful for us. Thank you. And Lady, I think you have a 3-minute time for public comment. So please come in and share your comments with the board.
Thank you, and good afternoon, Chair, board members, and MHBE staff. Thank you for allowing me the time and the space to speak on behalf of CASA. My name is Lady Garcia. I'm the Senior Manager of Health and Social Services at CASA. CASA operates a robust Health and Human Services Department, working closely with undocumented Marylanders who are uninsured. Our health department assists thousands of families each year in navigating the health and human services system through our comprehensive and culturally responsive public benefit outreach and enrollment program. CASA is one of the leading and most trusted organizations providing health support to the immigrant community, as well as the prominent advocate for immigrant healthcare policy. As a state, we know that legislative action has proven effective in reducing uninsured rates and uncompensated care costs. However, under current health programs, thousands of Marylanders are left without care due to the immigration status, particularly under the Affordable Care Act and the stringent provisions of H.R. 1, which require individuals to have the legal status to access care. A staggering 30% of uninsured Marylanders are denied healthcare solely due to the immigration status, and this number is likely to increase. The lack of access to routine, comprehensive, and affordable care has forced uninsured Marylanders to seek the most expensive type of care, emergency departments. This is not only unsustainable for hospitals, but also ineffective for long-term treatment of chronic conditions and renders an unjust system that excludes immigrant families from the healthcare landscape. To address this issue, CASA supported and led efforts to pass the Access to Care Act. Today, I'm here to express CASA's strong opposition to the proposed delay of this program that the board is voting on today. I echo the sentiment expressed in our letter dated October 9, co-signed by 103 other organizations, and respectfully, but yet urgently, call on you to reconsider this proposed delay. We must find solutions to ensure that undocumented Marylanders and those with various legal statuses gain full access to the state's healthcare system via the Maryland Health Connection. The Access to Care Act was intended to be a stepping stone towards equitable access to care in immigrant families, and we urge the state to uphold its commitment to the immigrant community. Thank you for your time.
Kat? I think that's all
Sorry,
the
it's so
public
hard to
comment.
do this on my cell phone
Well,
when
you
I'm
know what,
little.
Aika
you.
has joined, so we can hand it off to Aika. She has joined. So why don't we transfer to Aika to chair?
Gladly. Here you go,
All right,
Aika.
we'll make it easy. All right,
And here I
Aika,
was
we'll
gonna
switch
say,
it. Thank
Catherine
you.
is doing such a great job. Keep going.
So that's all we have for public comment, Aika.
Okay, great. Thanks, Michelle. Thanks, Catherine. All right. Any other comments, questions in general?
I can move into the executive report.
Perfect. Thanks, Michelle.
All right, so I am going to devote my entire report today to the federal government shutdown and implications of that, because I know that is front and foremost on everybody's mind. Cynthia, can we pause we've got the question slide up here. I don't know if there's just a slide for executive update, or we can get rid of that. Maybe, yeah, just pause it for a moment. All right, well, let me keep going on. All right, so the federal government shutdown. So let me talk a little bit about impacts operationally. We have had little operational impacts. We have a regular monthly CMS meeting, and our liaison for that is furloughed. So we are not having those meetings until they're back working. And we've also learned that there will be a little bit of delay for some of the regulatory work that's ongoing, such as the 2027 notice of benefit and payment parameters. So of course that's slowed down. But the federal hub that we use for eligibility determinations and federal funding that we're receiving from Medicaid and the reinsurance pass-through funding so far, that's all as is normal. So we're hoping that we won't see any impacts to that. Obviously, the largest impact to Maryland in the exchange is Congress not taking action on the expanded tax credits. Brad did a really nice job going through that in the rate review, talking about the examples so you can really see the impact that Maryland families are going to have. And one thing that's important to note, without the state subsidy, and we are so grateful to the Moore administration, to our General Assembly, and to you, the board, for helping get that state subsidy program move forward, because absent that, our consumers with APTC would have likely seen 95% increases in their premiums on average. They will see about a 35%. So still untenable, but it would have been much, much worse. The other big impact is, we know, the deferred action for childhood arrivals. We had to terminate coverage September 30th, so that's now in place. We have seen a little uptick in calls to the call center, asking questions about that, and again, trying to encourage folks for other sources of which they are limited for health coverage. And then another big impact will come January 1st, 2026, when our lawfully present immigrants under 100% FPL, or it's $15,560 for an individual, they will no longer be able to access tax credits through MHC Maryland Health Connection. When we ran our renewal, there was over 17,000 consumers in that group. So we don't know if they'll be able to afford the increase in the premiums without that tax credit or not. We will monitor that. We will report back on it. So those are the most critical impacts right now for the exchange. The other thing is just the impact to Maryland families. And so anyone who has a family member that's a federal employee, of course, paychecks are not coming in. And just want to reiterate that there is the state website. It's response.maryland.gov/federal public servants. And there's a list of resources there. We have been getting tremendous support from our federal delegation. Senator Van Hollen's office has been collecting information we've been sharing. They've been asking for information. We've shared it on numbers, on consumer stories. They are the gatekeeper for the rest of the federal delegation to get information out. We work closely with MIA on getting talking points. Congresswoman Elfreth's office has reached out. We know she's done town halls. Congressman Ivey did a kitchen table roundtable that I participated in. So there has been a lot of action going on from our federal delegation, and we're very appreciative of the actions that they're taking. So now what happens now? What happens if Congress does take action? And Joanne, this goes back to your question earlier. The exchange will work as quickly as we can. We will do as much as we can to get the enhanced APTs put back in place, and making sure that consumers get the most amount of affordability towards their health coverage. So that's the APTC issue. From a technology standpoint, what that would require is we would have to back out the state subsidy, put in the enhanced tax credit, put it back in, rerun the renewals, which would be, take time, and there will be confusion. We can utilize our direct communication efforts of texting and emails, and we have in the past done robocalls when we did the PHE Unwind. So there's things we could do to communicate. The other side, which Commissioner Grant spoke of and Brad spoke of, is having carriers actually file new rates. And that's a whole nother situation. So those two efforts combined, we'll look at all of them. Likely the timing to get all that done is a 3 to 4 week process. So then we'd have to look at, do we shut the open enrollment? Do we close open enrollment for a period, do all this work, and then reopen it? Do we then need to extend open enrollment, come back to the board and ask for an extension of open enrollment? So these are all questions that we're grappling with. And there isn't a perfect answer because we don't know what the outcome will be. If it's a clean extension, that has one set of options. If it's a clean extension with policy changes, that's a whole nother issue. So we will just continue to keep you updated as we learn more. And we are very much plugged into all the state marketplace network circles of trying to hear what's going on. But of course, everything we're hearing is that nothing is going on. Now, what we are doing in terms of communicating to our consumers and stakeholders, our messaging this open enrollment is that we want to retain as many consumers as we possibly can. That's our goal, retain enrollment. We want to maintain the trust that we've built with our current enrollees and stakeholders. We will be educating them about key changes affecting eligibility, enrollment, and costs, reinforcing the value of coverage. And we've been over the summer really preparing our consumers that higher costs are coming. We did this first in July with the DACA population, where we said, use your coverage now if there's any coverage you need. Likewise, in our communications going out now to our consumers, we're saying, again, higher prices are coming. Don't delay. If you have healthcare needs now, consider getting them now. Come back in and look at other options that are available. We continue to update our website and update our fact sheets and our talking points. So all the modals that we can use, the multiple ways that we can communicate with our consumers, we're doing all of those. It is going to be an incredibly challenging year. It will be challenging if we, in a good way, but if something does come forward and we can now increase the affordability, then we have, again, the added challenge of how do we communicate that? How do we keep our enrollees enrolled? In addition, we've had Aetna, of course, left the marketplace, and that was about 5,000 enrollees that we had to map over to another plan. Communication on that. We will have in fact, they're already airing our 2 commercials this year, and they're wonderful. And again, the whole message is things are changing, times are tough, we're here to help. And that's our message. We're here to help as best we can, whether it's helping you find a different plan or whether it's helping you connect with resources that could provide health coverage. We're so grateful to our consumers that have provided stories that we can then share with the federal delegation that are willing to go speak to committee hearings. So that's really where our focus is right now. And our team is working, of course, overtime to get all this done and to stay on top of it. And so grateful that we have such a mission-driven staff. So I'll stop there. I'm not going to talk about anything else because this is most pressing unless there are other questions, but that's the update on where we are right now in open enrollment.
Thank you, Michelle. I see your hand. Feel free to go, Marie.
Thanks. Michelle, and I got the mildest hint that there might be something coming together today, but just the mildest. So I'm not sure, but say miracles happen, something comes together this week. Would the exchange consider looking at delaying open enrollment at all should something come together before November 1st? Or is that we'll cross that bridge?
No, absolutely. I think everything's on the table.
Okay.
The issue is how can we make this least painful and the best option for our consumers? And so our goal is to make health coverage as affordable as we can. We do have a little bit of benefit. The state of Idaho, their open enrollment starts on October 15th. And just as an example of, they didn't have any state subsidy to help. 2 60-year-olds making combined $85,000 a year, their premium increase is $18,000 a year. Now, clearly, that's not affordable. Did talk to them this morning, was on a call with them this morning. I asked, well, what are you seeing at this early time? And so we're able to share communications about, he said, really where they're seeing the most comments is through their social media sites and, trying to address things that we as an exchange can't address. But that's a good heads up that we can at least learn from Idaho of things to pay attention to and how we respond. So.
Anybody else have any questions for Michelle?
Thank you for your support. And again, if any questions come up at any time, just, send them off, and we'll get answers right away.
Perfect. Before we do the consumer updates, I just wanted to check in if we had any board committee reports. I know Finance Committee met, so Maria, I wanted to turn it over to you.
So I don't think Maria is here, Maria
Oh,
Rodriguez, but she did send me her Finance Committee report.
okay, perfect. Thank
So
you.
unless Ken or Doug wanna to wing it and go, I can read from her report.
It sounds like it's you, Michelle.
Okay. I'll read from her
Yeah,
report.
I apologize. I would be glad to do it, except I jumped in the meeting late, so I don't have a
Yes.
comprehensive background on
No
it.
worries. I will read from her report and then add in if I've missed anything or if there's anything you want to add. So the Finance Committee did meet on October 16th. There was a financial review by Tony Armiger. The materials that were reviewed were the fiscal year 26 year-to-date financials through August 2025 and the fiscal year 26 versus fiscal year 25 comparative results or comparative financials. The highlights of that, actually, I will send this out and you can all read the highlights because there's many of them. So let me do that. We'll send this out to you. Just got this morning. Then compliance and audit report was presented by our Director of Compliance, Scott Brennan. Materials review was a tabular summary of OLA findings and recommendations. The OLA, which is Office of Legislative Audits 2025 final report, and MHB's response to the OLA letter dated June 12th, 2025. And the overall status for that is there are 4 findings that have been fully implemented, and 1 is partially implemented, and 1, the FTI study remains pending. And then finally, there was a privacy and security update by Saika Atta, our Deputy Compliance Director, or Associate Compliance Director, and the materials reviewed there were the fiscal year 26 Q1 privacy overview, which was from July 1st to September 30th, 2025. Highlights, there were no major breaches. Routine privacy incident reporting and connector entity remote reviews were completed in September. And the next steps are just continuing to monitor fiscal year 26 IT and service center costs to assure alignment with the budget by year end. Oversee MHB's progress in completing a joint FTI study with MCPA, and I'm not even sure what that is. So when our staff can jump in if they know the answer to that, and then maintain quarterly reporting on privacy and incidents and compliance metrics. And that was the end of Maria's report. And I will send this out. She sent it in writing, so I'll send it to everybody.
Perfect. Thank you. Any questions for Michelle?
Or the Finance Committee.
Finance Committee members, Ken and Doug. Awesome. Well, thank you so much. And I will turn it over to Tamara for the Consumer Assistance Connector Entity Grants.
Good afternoon, everyone. Thank you for having me today. Just want to give you an update. I'm coming to you with better news than I did last month. So I'm coming to you to request a revision to the extension request for the CE's modification extension. Next slide, please. I feel like I want to go over this timeline word for word, just so to keep it on record and because the conversation is being recorded. So timeline for the CE grant federal match request, March 2025, MHBE notified of changes needed to the federal match dollars for the CE grant. which include two 60-day review periods. April 2025, board approved a 3-month extension, went very well. April 25, request for RFA was sent to MDH for CMS to review. May through July 2025, a decision was made for the grant process. August 2025, MHBE notified there will be a hold placed on the RFA and additional information will be needed. September the 3rd, additional information was provided to MDH. September the 15th, board approved a 9-month extension with reduced funding only for state dollars of $2.5 million. September the 26th, we received fantastic news that there was a possible pathway, not a path possible, a pathway to include 50-50 funding for the CEs. October the 4th, MHBE issued revised extensions reflecting the new funding amounts, which I'm happy to report. Next slide, please. And just want to go over some of the numbers. So before there was a not to exceed amount of for the program, 9,300,000. With the budget cuts right now, there is a change. It will be $7,059,000. Now this is definitely different from what we had last time. Before there was 67% federal funding match. Now will be only 50-50. So what does that look like? That is definitely a 17% cut for the CEs. While it may not cut a lot of staff positions, prior when I came to, to the board, it was definitely cutting a lot of the positions and putting the CE program at risk from operating through open enrollment. The CE reduction and relationships that we have and partnerships we have all over will definitely keep the CE program open. It will definitely target those meta areas as we want them to do. Also, the CEs will be doing all Medicaid and QHP. Before when I came to you on September the 15th, it was just QHP mixed households. That has changed to Medicaid and QHP, which is a great thing. Next slide, please. I want to go over the strategic planning and what the CE program will be doing. So between now and open enrollment, CE program will be doing health education, enrollment for the meta areas. Also, we will be doing CE referral process. So what does that look like? So when a person comes in and enrolls with the CEs, they would do a warm handoff to a broker to get a relationship with a broker. And this is done so we don't fill our books up with redeterminations and reappointments for people who are already enrolled. This leaves space for the person to go out and actually boots on the ground to go out and get individuals signed up and enrolled and give them health education, which we know is very important to all communities. We also will forward the broker, like I said, to the enrolling. We also do redebts, forward those individuals to the local health departments and DHS, which I have talked with the local health departments, and they're definitely on board with making sure those referrals and everybody has an access pathway to make sure that there's no wrong door and no one is left behind from getting access to healthcare coverage. Next slide, please. Okay, of course, you already know this. We cover all of the counties. Like I said, no one will be left behind. Just want to give another overview too. During this process, we know that the funding is different, and we know that the CE program may have to operate differently because we don't know if we're going to have that same $10 million that we used to have for the CE program. So what we're going to do is we're going to start a work group up probably right after open enrollment. This work group will study and see how, first we're going to see how effective the CE program is. We also going to see what the intent of the CE program was supposed to be to make sure that we're abiding by the ACA guidelines and requirements. But just get the work group so we can see how we can move forward with spending dollars and make sure that we're accounting for every dollar and getting everyone enrolled, when it's possible. Next slide, please. Okay, here is the grant amount from the new budget. I'm not going to read this verbatim, but I'll look at what you guys approved for July the 1st through 9. I'm sorry, September 2025 to what the new amount will be now. This is double what you guys approved by you guys. I'm sorry, double what the board approved for the last modification, taking us through open enrollment all the way through June 2026. So again, this still is a 17% decrease, but it will definitely keep the program operating and it will cut less jobs, maybe one or two, rather than almost at least over 50 to 60% of staff. Next, please. Here's the motion.
Thank you for walking us through that. I want to open it up to others if you have any questions. And thanks for bringing in
Hi.
this suggestion too, because I know we've had a lot of conversations and comments just centered around this and wanting to minimize outreach, especially across Maryland. And so, Joanne, I see your hand first.
Hi.
Hi, this is really good news. It's nice to come back to this and appreciate the additional funding to help cover those gaps. And I will be really interested in the work group. I think that's going to be helpful to really understand if there's any room for improvement here. Were there connector entities that had to do some staff layoffs, and do we know if they were able to restore any or all of those with this additional funding?
Yeah, so there was only one CE who actually laid people off. I'm going to say in the beginning of September. We have recently talked with them and they have hired the individuals back.
Okay.
Everyone else did not lay their staff off yet. They kept their staff on to see exactly what was going to happen, and also because they were still getting federal and state dollars through the end of September.
Okay, and just to clarify, I do appreciate too the ability to do Medicaid households and not just mixed households and QHPs.
Thank you so much for that. Any other questions?
Thank you, Tamara. This is very good news, actually. My question is, when you're looking at streamlining the process from a staff perspective, are there specific things that are being recommended to kind of maintain enrollment and do some of this recruitment for new enrollees? Is there directives coming from us, from MHBE?
Yes, there's definitely directives coming from us. There's directives and guidance. We have meetings, Ken, every month, and we go over best case practices. We've been having them a lot regularly because of open enrollment and all of the changes. So it could be twice in 1 month sometimes because all of the changes. But yes, we're giving guidance to make sure they have people in meta areas and boots on the ground. I'm gonna give you an example. We had one CE who shared with me their books were already filled with redetermination appointments. Of course, redetermination appointments are people who are already enrolled, and those individuals can clearly, for Medicaid, go to the local health department and local DSS office. So we want to keep their books open for actual new enrollments, going out there in the meta areas, seeing who needs assistance, who's not a part of the system, and helping those individuals get enrolled. But we give definitely guidance, strategic planning, and helping them far as marketing and far as how to go out and get these individuals signed up.
Good, thank you.
You're welcome, thank you. Any other questions?
Catherine.
Yeah, I was just wondering if you have any concerns despite this additional funding coming down the pipe of any of the connector entities discontinuing with the program.
Yes, I do. So it's always that possibility. I will share with you right now. We do have one CE who has chosen to leave the program effective after open enrollment, and that is one of the health departments. So that is the Eastern Shore. So yes, very concerned. I did a meeting with them today. I called it an exit interview just to see best case practices, what we could have done differently. And they said that we were fantastic. There's nothing they can do differently. It's just the juice wasn't worth the squeeze as far as the funding. So I'm always concerned when it comes to the funding.
And I'll just add, Kat, we are working with Maryland Department of Health and evaluating this because two of the connector entities are the local health departments, and we have one, actually two in Department of Human Services and one in a local health department. So we are looking at how best to utilize what's already there serving other folks. And then again, our goal, how do we find the uninsured, which is the intent of our navigator program.
Yeah,
Are y'all
we'll,
going, oh, are y'all going to work with the local health department to try to recruit another entity to sort of pick up what is lost?
So yes, we are. So just to piggyback on what Michelle said, we have 3 health departments. So out of our CEs, we have 6 CE entities. Out of those individuals, 4 of them are actually state office buildings. So 3 are health departments and 1 local department of social services. So that's who has 4 out of 6 of the grants. So yes, we're working with all of the health departments to make sure that there's a streamlined path for individuals for Medicaid. QHP can be done by the navigator. Okay, for the rebidding, we are working with our legal department because we want to make sure that it's a streamlined process. I did speak with, the entity today, and they're definitely willing to help streamline the process to make sure it's a smooth transition. What we're planning on doing is bidding out the remaining time of that particular CE entity contract from February 1st through June 2026. And we definitely have at least 2 to 3 people who would like to bid on it. And these are already entities that we already have, not anyone new.
That's helpful.
Thank you.
You're welcome. So any other questions?
These
All
are
right,
great
thank you so much.
questions. Yeah, thank you so much. And overall, good news. I move to approve the Maryland Health Benefit Exchange request to revise modification number 2, increasing the not to exceed amount from 2.5 million to 5.1 million for the period of October 1st, 2025 through June 30th, 2026 to support Medicaid and qualified health plan enrollment and education. Do I have oh, I see Catherine. Catherine, second, all in favor?
Yeah.
Okay, thank you. I have everyone.
Thank you so
Thank
much.
you. Thank you. Okay, moving on to Joanna. I think you're going to talk to us about the proposed plan certification standards.
That's right. Thank you. So happy to have this kind of preliminary conversation about our 2027 plan certification standards. We can go on to the next slide. All right, so just some background for our newer board members. The board sets plan certification standards for our plans sold through Maryland Health Connection. And those plan certification standards encompass plan design, operational requirements, and other requirements that we may deem appropriate. Past examples of certification standards the board has set include requiring NCQA health equity accreditation for carriers to operate through the exchange and requiring our dental carriers to have pay now functionality for their plans, meaning they have the ability to accept a live transfer via kind of a web link at the end of our enrollment process. There's a link someone can click on to be routed to the carrier's payment portal to make their first month's premium payment as soon as they conclude their enrollment on MHC. And then particularly pertinent to today's conversation are the value plan standards, which fall under our overall plan certification standards. Each year we bring new plan certification standards that we're proposing to the board. Past approved plan certification standards kind of exist on and are evergreen unless the board or staff would recommend to the board that they change. So we don't bring that whole body of plan certification standards that have been approved in the past to the board every year, just anything new or changing. Our value plans are our standardized plans, and we use them as a policy tool to both support affordability and access, simplify plan choice, and promote health equity are some of our primary objectives. And I'm going to get more into the genesis and background of our value plans in the next few slides. The two plan certification standards that we have for discussion with the board today are one to require alignment with primary care investment targets under the AHEAD model, the state model with CMS that's in the process of negotiation that will be replacing the total cost of care model. And then also, as I mentioned, our value plan standards. And then of course, we'd also like to hear any feedback from the board on potential standards that we're not proposing that you might want us to consider and look into and bring back to the board in the new year. Next slide. So some background on our value plan standards and how we've come to what we are proposing to the board today for discussion. Again, we're not asking for a vote at this time. We have an annual value plan work group that starts meeting in the summer and meets through the end of the year. That work group comes up with proposed plan standards, which we take to our standing advisory committee for feedback in the fall. And then today, of course, we're having our preliminary discussion. In the fall, before the end of the year, hopefully, the federal government will release their actuarial value calculator, which is a tool that we need to finalize the standards. So once that tool is released, we run our proposed plan designs through that tool and assess whether they comply with federal requirements. If not, we iterate some potential changes to bring them into compliance, take that back to the work group for a quick discussion, bring that back to the board. Hopefully in January, we'll have had time to do all of that. We'll ask the board to vote on the proposed 2027 standards at the January board meeting. That'll be followed by a formal public comment period. As I mentioned, kind of this summer through fall, we're going through an extensive stakeholder process to gather feedback on our value plan standards and plan certification standards. Then in February, we'll come back to the board, hopefully to ask for finalization of the 2027 plan certification standards so that they can be in place when carriers file their rates and forms with MIA in the spring of 2026. And then those standards will be in effect for plans effective for January 1, 2027 coverage. So we always have this process of getting started about 1.5 years ahead of when the plan standards would actually be in effect so that we can get everything squared away in time for the carriers to incorporate it in their plan and rate designs. Next slide. Some additional background on primary care. We are bringing to the board today, this is a bit more preliminary than the value plan standards, but again, all just for discussion, a proposal around primary care investment for our carriers. So as just kind of backing up a step on primary care and its value, research finds that primary care is the only specialty that an increase in it results in lower mortality and more equitable health outcomes. And that's quoted from a National Academies report that was itself quoted in an MHCC report on primary care that was released recently. And multi-payer alignment, so bringing together the commercial market, Medicaid, Medicare, more than just one healthcare payer, helps to align incentives for primary practices to transform the way they deliver care, to do so in a way that is more advanced and offers kind of better care management and availability of primary care for individuals. As I mentioned, MHCC recently released a primary care investment analysis and recommendations report in which they found that primary care spending has been pretty much flat over the last couple years from a couple of different metrics. And I think we can move on to the next slide. So kind of where this is going is in the AHEAD model, which is, as I mentioned, the replacement for the existing agreement with CMS that governs our total cost of care model. The AHEAD model is a voluntary alternative payment and delivery model that's being designed by CMS for voluntary participation by states. And we have signed an agreement with the governor has signed an agreement for the state to participate in this model. And one of the requirements is that the state establish an all-payer primary care investment target for 2027 through 2030 to be that initial period to be established by October 26. And so we're bringing this to the board today both kind of as an educational opportunity to share that this is coming for the state broadly, including payers in the individual market, and to inform and provide background for this proposal, which came out of conversations we had with MHCC. And I will say that there's still a lot of work to be done as we've discussed with our sister agencies and kind of getting from where we are now to where this primary care investment target is set. The target itself has not yet been set. And so when we return in January with more solidified proposals for the board, you know, the state may be in kind of a firmer footing in terms of what that proposal looks like, but wanted to kind of put this before the board today, nonetheless, acknowledging that it's still on the early side of the trajectory of development of this primary care investment target. Next slide. So the proposed certification standard here is that carriers offering individual or small group plans on exchange would commit to meeting the primary care investment target set by MHCC, that is to be set. And then for further discussion with stakeholders is the feasibility of requiring carriers to pay for certain services that really facilitate the infrastructure of advanced primary care without cost sharing. And this, as you know, as I've explained, would align us with those AHEAD model requirements and recommendations in the MHCC primary care investment report. And I'll pause there and would love to turn it over to Dr. Jacobs, who's the real expert and one of the leaders in this topic in the state, to add anything that he'd like to share.
That was incredible, Jane. I really, you seem like the expert here when you present. So excellent job. So I had suggested that that this be included as a discussion topic, as was mentioned. It is still early. The state and CMS still need to sign the agreement. The Maryland Healthcare Commission is charged with setting these all-payer primary care targets. And just to emphasize something that was mentioned, the fact that these investment targets are all payer, obviously this, the QHP certification standards is solely in the individual market. And so as we think about the best path forward, there's going to be conversations with stakeholders, conversations with legislators. One of the high level objectives here would be when MHCC sets this target, which would have to be done by October of 2026, what are the mechanisms in place to make sure that we hit the targets? Because CMS is going to hold Maryland accountable for hitting these primary care targets. And so we want to make sure that collectively we're successful in the AHEAD model. And so the second part here that's in italics related to these different codes, I'll just add a little bit of additional color and background here. This was included as a recommendation in the MHCC report that came out, and I'd be happy to share that report with board members. There are these codes, advanced primary care management codes, that now traditional Medicare is paying for. And so to the earlier point of multi-payer alignment, these per member per month codes really reflect the provision of advanced primary care, having elements of the primary care setting where patients can message with their providers back and forth through patient portal messaging, having a care plan, being held accountable to quality measurement, and population health management techniques. And so in an effort to really promote this type of primary care, it's not just kind of improving payment for primary care practitioners, but also just ensuring better access to primary care doctors. So, but as was mentioned, this is, it's still early. It could very well be that when we come back in January, we don't think this is necessary or the right path forward at that time. But wanted to just bring it up here for discussion. So thanks for the opportunity.
And I do have more on the value plan set of proposals, so I can continue on with that and then pause for the overall discussion. Yeah, next slide. So some more background and kind of where we're at with value plans. So as I mentioned, the value plans are what we term our plans with standardized cost sharing. They're generically referred to in the marketplace policy world as standard or standardized plans. And when you break that down, the benefits that need to be covered under ACA compliant plans in the individual and small group markets are largely already set through a federal and state framework. So the benefits are very minorly among plans. They're largely consistent. There's some variation around whether a plan covers adult vision or adult dental, but that's really the only significant service that varies in terms of coverage among plans. So benefits already largely standardized. Cost sharing is sort of loosely standardized. The federal government sets the metal levels, which we talk about a lot. So the main ones being bronze, silver, and gold. We have small participation from carriers also offering platinum, but primarily our carriers offer bronze, silver, and gold. And each of those plans is a different, has a different range of actuarial value. Actuarial value, to get a little bit into the weeds here, is a measure of plan generosity. So on average, a silver plan will cover 70% of claims for an average enrolled population. That doesn't mean any single individual will get 70% of their medical claims costs covered, but on average across the enrollee population, about 70% should be covered. There's a little wiggle room that the board helped to establish earlier this year in terms of a de minimis variation from those thresholds. So bronze is 60 or 65%, gold is 80% in terms of the amount of claims that on average need to be covered. So within those metal level frameworks, that provides some guardrails around sort of how high deductibles can be, what level of cost sharing can be assigned to services, because the plan does have to meet that overall threshold of covering a certain percentage of claims. However, beyond that, it's really up to the plan how they design the cost sharing in their plan to meet those actuarial value standards of the metal level. There's one exception. The federal government sets a maximum out of pocket. So that's the most that an individual or a family can be required to pay by the carrier towards their claims in a year. And after that level, that threshold is hit, the carrier would then cover 100% of claims. That's typically quite a high number. Only roughly 2 to 3% of enrollees typically reach that. So the cost sharing assigned to benefits is a very meaningful design feature to enrollees. We require carriers to offer one value plan at each of the bronze, silver, and gold metal levels. And we see that about a third, a little more than a third of our enrollees do choose value plans, which we're pleased by that uptake, and that enrollees are seeing the value in the plans. All right, next slide. So I covered some of this material already in terms of how AV works and how the metal levels work. And what we were doing with value plans is standardizing that cost sharing. So every value plan at the silver metal level will have the same copay for a primary care doctor, the same ER copay. We do prioritize copays across value plans, so the majority of services in value plans are covered with the copay structure. There's lots of consumer feedback we have received, and that's been published to indicate that copays are preferred by enrollees because it's a predictable, kind of easy to understand amount that has to be paid relative to coinsurance, which is a percentage of a generally hard to figure out in advance total claim cost. When we are constructing our value plan cost sharing standards, we do have to be really careful and attentive to the trade-offs in those plan designs, because if we reduce cost sharing for one service, that may cause the generosity of the plan to increase when it's run through that federal AV calculator, and it could put it out of range. So then we have to, because we've reduced cost sharing for one service, we may have to increase cost sharing for another service to balance that out. It's often the analogy is used that if you squeeze the balloon, it just pops out somewhere else. There's sort of you have to stay within the framework of AV. So it is a delicate kind of dance, and one that we go through each year with the work group and with our consulting actuaries and in consultation with MIA to do lots of iterations, particularly when we were initially devising the value plans. And a shout out to her board member, Joanne Volk, who was one of the co-chairs of the group that came up with the initial value plan designs, which have stayed very consistent over the years. Next slide. So goals with our value plans, as I mentioned, improving healthcare access and affordability, and how we operationalize that is by trying to maximize pre-deductible coverage using a copay structure, and also promoting health equity through plan design, which is a recommendation out of another stakeholder work group we had in 2021. And I'll get into a little bit more detail about how we've approached that concretely in the plan design. The standardized cost sharing also promotes insurer competition by increasing transparency and enabling apples to apples plan comparison, which kind of follows right into the next point of simplifying plan shopping. So with the already largely standardized benefits, now standardized cost sharing, it enables consumers to shop based on price, network, and quality being the three variables that they're looking at. And when I say price, I mean premium. So they're not trying to look at one plan that has a $12,000 deductible, but a $50 primary care copay and weigh that against a plan that has a $14,000 deductible or $1,400 deductible, but a $25 primary care copay, and try to work through the intricacies of what is the best kind of balance for them. They can look at the value plans across every carrier, know that they're largely the same, and then look at what is the price, what is the network, and what is the quality rating of that plan. But also to emphasize, carriers are not limited to only offering our value plans. They have to offer one at each of those metal levels. They can also choose to offer up to 2 plans entirely of their own design. So carriers can offer in the individual market 3 plans per metal level on exchange. So they have flexibility in their non-value plans to develop that plan design however they think may best suit the market and their enrollees. Next slide. So yes, as I mentioned, these grew out of our affordability work group convened in 2019. And there's sort of 2 iterations of affordability work group. Our first affordability work group in 2019 suggested our original value plan launch, which had a little bit of standardization around cost sharing. There were copay caps, and a handful, like 3 or 4 key services, had standardized cost sharing. And we had $0 insulin and glucometers in certain plans. So it was sort of a light touch standardized plan design in 2020. In 2021, as I mentioned, our health equity work group convened and recommended trying to reduce cost sharing for health conditions that have a high level of disparity among those, such as diabetes. And then in 2022, we reconvened another affordability work group to take a look at our value plans over their first couple years of implementation and provide recommendations for the future. And that is where the recommendation to standardize value plans grew out. We launched those standardized value plans in 2024 and added on to the previous $0 requirement for insulin and glucometers, $0 commonly used diabetic services that are part of kind of a common care maintenance for diabetic individuals across all our metal levels. And that was created in conversation with our work group and also inspired by work DC had done to implement very similar standards in their standardized plans the year prior. In 2025, we made very few changes to those standards, a few tweaks. In 2026, the work group recommended and the board approved some reductions to lab copays where we could afford to do it within the AV framework. And then some minor technical fixes and changes to plan design to stay within those limits. Next slide. So for 2027, we recommend, again, maintaining our 2026 cost sharing, except to the extent that it needs to be adjusted based on the release of the next actuarial value calculator. So we'll take a look at that and incorporate any needed changes in our recommendations to the board in January. We did do some pre-meetings with our navigators and brokers to get more feedback on how consumers like the value plans, if those consumer assistance workers are getting any feedback around changes they would like. And overall, we largely heard support for an appreciation of the existing value plan design. We also went through an extensive analysis to look at the value plans and compare them to the most popular plans at the metal level, at the same metal level that were non-value plans, to assess again if we thought any changes were appropriate. And again, largely kind of felt that the existing value plans are meeting a need and are pretty well designed to achieve their goals. The one change that kind of significant change that we're in discussion with the work group about, and the work group is still meeting, they haven't voted on these changes yet, is to add a requirement to the diabetes services to cover at least one continuous glucose monitor at no cost to the enrollee. And in addition, to include a requirement that carriers provide easy to understand information on their website that specifies the services that are included in the $0 diabetes benefit, because we want to make sure that consumers are aware that this is in their plan if they choose a value plan, and this is inspired by some work Colorado has done. Lastly, we are planning to do some consumer testing and analysis of the term value plans over the next year, because we are concerned and getting some feedback that maybe that doesn't quite convey what we hope it to convey. We want them to appeal to consumers, not to potentially sound like they're the cheap, sort of low cost option, like the store brand health insurance plan. So we're going to be thinking about that, and that'll be a little bit outside of the affordability work group, but some work that we'll be doing with our marketing team. So that's a recap of where we are on the value plan design. Next slide. Okay, and then I have a bunch of appendix slides that we don't need to go through, but are there for additional reference if the board has other questions. And with that, I'll pause.
Thank you so much. This is rich, and I think it's a really great walkthrough, just from some of the things that we've done as a board, especially for new members. I'm happy to turn it over to Doug. Speaking of new members.
Yeah, no, totally. So on the value name change, I just thought it might be useful. Is when I was at CMS, I was leading the value-based care work that the Center for Medicare was doing. So value was in that name as well. And CMS had actually done focus groups related to that term, value-based care. And similar to what you were saying, a lot of the reaction was that when people heard the term value, they're like, oh, I'm not sure that that's actually something that I want because it's cheap. And so, and when you think of healthcare, you want high quality healthcare. So they weren't making that connection. So I just wanted to add additional evidence to maybe the name could potentially be useful.
Yeah, just to piggyback on that, we started to call one of our plans the core plan. I don't know, just food for thought in the future.
Yeah, we're very welcome any suggestions. I've been kind of scraping my mind to think of alternatives. So if you have any, send them my way.
Johanna, I have a comment and a question. My comment is I've had the privilege of working with the MHBE staff on the value plans for the last couple of years, and I want to give a shout out to Becca Lane. She has done a remarkable job assembling a very diverse group of stakeholders to serve on the work group, and also from a leadership perspective, making sure that everybody is validated for their participation and engaged in the discussion. And as you said, it is not an easy exercise. It's a very delicate balance. My question is to Doug. Back to the AHEAD model, since the primary care physician is going to be the pivot point of a lot of this change, and we're losing primary care physicians and internists, this may be out of the MHBE realm of participation, but is there anything that CMS or anybody else is doing to kind of enhance the number of primary care physicians that we have?
It's a great question. So I think it falls into several buckets. One is overall payment of primary care, and there have been changes on the federal level where CMS is now paying for these new, they're called advanced primary care management codes, where traditional Medicare never used to pay for advanced primary care, but now it's a fairly sizable payment that these practices could get on a per member per month basis. And it could make primary care more attractive if there was, but that's more of a longer term. Like you'd have to have more people go into primary care residency programs and graduate from them and practice in the field. And there's also there's also discussions with some of the with MDH on some of their like supply side workforce work related to primary care, particularly as the state is thinking about especially the Rural Health Transformation Program. So I don't know if that's at all helpful, but there's multi layers to it as you're picking up on.
Thank you. Joanne, I saw your hand first.
Yeah, and now I have to piggyback on Ken's comment. I remember from my days on that group that Becca Lane is awesome, and really just walking through the whole, support for the committee members to understand these complex trade-offs. It was a great experience. I appreciate that too. I'm looking forward to learning more about the AHEAD project. And I mean, again, to your point, Ken, it does seem like it does look at this holistically, that you can't put bodies where they don't exist, but to the extent that we have people in behavioral health and primary care, that I assume this means we're using the exchange as a purchaser to put these certification or these requirements on issuers to cover this, but then also thinking about the reimbursement and what it means for cost, and potentially even excitingly, what it might mean for reinsurance costs. So I assume we'll all get smarter on this in the months to come. So I really appreciate that. And then I think the one question for Johanna on the diabetes designs, the Colorado reference, is that information so consumers can understand whether or not their continuous glucose monitor is covered as a durable medical equipment benefit versus pharmacy? Because I know that has implications for how they get it and availability and so forth. Is that what that was referring to?
That is part of it, but broader. So we want to make it clear how consumers access the $0 continuous glucose monitor, but more broadly, we just want to make sure that all of the $0 diabetes services are clearly enumerated so that consumers are aware that there is $0.
Okay, thank you.
Marie?
Thanks, Aika. Yeah, I just wanted to chime in on a couple of those comments about primary care investment in Maryland. So since the total cost of care model, maybe a couple of years after, we actually have a Medicare primary care program in Maryland. So Medicare is actually a pretty generous payer in Maryland already to start. So I think even despite that backdrop, we have challenges, but I just want to make sure folks were aware of that. And similarly, Medicaid, there's been a lot of work over decades in bringing Medicaid's primary care reimbursement up in Maryland. And as a condition, I think, of the AHEAD program and moving forward, Medicaid is moving on its own primary care, advanced primary care payment program. So, and I think more to come too. I love active purchasing, but I also want to make sure folks are aware of a couple of things. The primary care investment target is going to be an all payer target. So it's going to be all the payers including Medicare, Medicaid, and all of our commercial market, including self-insured. So in Maryland, that's about 2.5 million people. And I think, as we've just been talking right now, the on exchange individual market is 240,000. So it's a great thought, but I think strategically, we're going to have some big discussions statewide about how we do primary care investment thoughtfully.
Thank you for that. And your last comment, I'm sure, is at the forefront of everybody's mind as we talk about all of the changes that are in the pipeline. So, any other questions for Joanna? If not, I can turn it back over to you for the waiver amendment.
Thank you. And yes, we can scoot through these appendix slides. And I will actually have one item to squeeze in before that is new. It was not in the materials that were initially sent to the board, but we wanted to include it here. It's sort of a recently breaking project that we've been working on, which is, we can go on to the next slide, to secure a consultant to assist us with planning for implementation of the Medicaid eligibility changes that go into effect later in 2026 and in 2027. Most significantly, Medicaid work requirements for the ACA adult expansion population and more frequent redeterminations for that group. So we have been working with, we have been drafting in consultation with MDH, expedited procurement to get someone on board to help us with this body of work, because it is a very short time frame and we want to make sure that we get it right as much as we can the first time. The award will depend on confirmation that state funding is available to support the state share of it. We didn't budget for this in our FY26 budget, which was prepared, more than a year ago when we submitted it, and we didn't foresee this work. So we are in conversations right now about whether there is funding available for it. If the answer is no, we do have internal state policy resources between us and MDH to move this forward, but this would be a nice to have to help us with this implementation planning. We hope to make the award in December, and that would require an ad hoc board meeting in late November or early December. So we wanted to give you a heads up about this, and we will be reaching out if this does kind of all come together to schedule that ad hoc board meeting.
Great, thank you. And thank you for the heads up.
And then next up is the waiver amendment. Yes, so an update on the waiver amendment. We covered this in our previous meeting. This is the amendment to our 1332 waiver to allow all residents to enroll on exchange regardless of immigration status. Of course, the underlying existing waiver that we have is to give us the authority to operate the reinsurance program and receive federal funding for doing so. That waiver amendment was approved in January, as we discussed at the last board meeting with, we had put in our application that we would implement for coverage effective January 1, meaning for this open enrollment period. Due to recent federal developments, as we discussed, the significant workload of implementing the Medicaid eligibility changes, as well as changes to QHP enrollment from the June program or July program integrity rule, which required a lot of implementation to be done in August and September. So really sucked up some of our time over the summer and fall. And now we're shifting quickly, as I shared, to look at these upcoming Medicaid eligibility changes that really impacted the resources we had available for implementing this waiver in January 2026. So we did propose and solicit public comment on delaying implementation of that until 2028. And just to be clear, individuals of all immigration statuses are able to enroll in ACA compliant plans off exchange by going directly to a carrier. So anyone can come to the Maryland Health Connection website and use our what we call anonymous browsing tools to look at all the plans available to them, get an estimate of the premium, compare plans and benefits, and then take that information, if they're not eligible to enroll on exchange, and contact an insurer directly to enroll in an identical off-exchange version of the plan. So coverage is still available. This waiver amendment would not have provided for any financial assistance for individuals who don't have a legal immigration status. So financially, they're in the same boat, whether they would have enrolled through the amendment or on exchange if the amendment were in place, or if they enroll off exchange directly with the carrier. Next slide. We will, as I mentioned before, we would implement before January 1, 2028 if resources allow. And we have put in our letter to the federal government that we would give the departments of HHS and Treasury at least 6 months in advance, because it requires some coordination with them on changes to our data reporting. Next slide.
Johanna, excuse me, will you also mention the brokers that are available, that we have brokers that can serve?
Yes, absolutely. Our navigators and our authorized brokers are available to serve individuals as well, regardless of immigration status, so that consumer assistance support is available to the entire Maryland population. So we had a 30-day comment period. It closed October 5th, and we've included those comments in our draft letter to submit to the federal government. We received 2 comments and then a third received after the deadline, but we wanted to include that, as it is the comment that the representative from CASA mentioned that had sign-on from a number of organizations. So the comments we received did express concern with the delay. We understand that. We were also very active in working with the legislature towards passage of the Access to Care Act. So we are, this is not something that we're happy to be coming to the board and to be proposing to CMS. It's really due to the circumstances we find ourselves in, and with recognition that many of our resources are still available to individuals who would have been affected by the waiver, and that they are still able to enroll in coverage off exchange. Next slide. So the summary of public comments is here. I won't go through the details of them. You can see the individuals that commented, and as I mentioned, they will be included in our submission to the federal government. And I am happy to get into any more detail in those if the board would like. Next slide. This is an overview of the implementation that we are proposing to CMS, which, as I mentioned, would target that January 1, 2028 coverage effective date, unless we are able to implement sooner. Next slide. Happy to take any questions.
Thank you. Any questions from folks? Joanne?
Yeah, sorry. I feel like I wait to not be the first. Just so I am clear, the only difference is so navigators and brokers and the language assistance and the plan comparison are all available to everyone regardless of immigration status. It's just that the population intended for this waiver will then get enrolled in an off-marketplace plan. Is that the main difference?
They would not be able to complete their enrollment on Maryland Health Connection. They would need to enroll directly through the insurance company's website.
Okay, but the support and understanding their plans, options, and the language assistance and in-person assistance and all that is still available. It's just the enrollment incurs.
That's correct.
Okay, that's helpful clarification. Thank you.
Anyone else? Marie?
Yeah, I just wanted to, nothing about this makes me happy. I understand this, but it's a really hard decision. I appreciate it's one the state has to do. I know that our agency is making sure that we also we already have quite a bit of multilingual support, but that we're beefing up our support for our immigrant community in advance of this change. But I just, I will vote to approve this, but I just wanted to get that out there.
Thank you for those comments. And I think that a lot of us feel and share. This is a tough position. But thank you for naming. Anyone else? Okay, I move to approve submission of the 1332 waiver amendment implementation update letter as presented to the Centers for Medicare and Medicaid Services, CMS, and the Department of Health and Human Services and the Department of the Treasury. Do I have a second?
Yes, so moved.
All in favor?
Okay, thank you.
Thank you. And thank you, Joanna. Okay, moving us along. We have, I believe it's Teresa who's next from the Broker
Yes.
Achievement Awards.
Yes. Hello, everyone. My name is Teresa Battaglia, and I am the Deputy Director of Marketing under the leadership of Maggie Church. I am also the co-chair and annual Broker Achievement Award representative here today. Thank you so much for allowing me to present on the Broker Achievement Awards sponsorship opportunities. Just to give you a little background about the MHBE gift solicitation and fundraising policy. Board approval is required before any solicitation or fundraising efforts commence. During the solicitation process, it should be made clear that donations will not confer any special access or benefit in the contributors dealing with MHBE or the state. The funds solicited should not result in personal benefit to any MHBE employee or officer. And the Assistant Attorney General's office should be consulted to ensure ethical and other statutory compliance. The purpose of the Broker Achievement Award is to congratulate and thank the top 100 brokers who had the highest enrollment for individuals and small business during open enrollment. This is an annual event that MHBE plans along with their committee. We procure the event location, the venue. We provide a plated lunch, trophies, printed program booklets, and each winner receives a Maryland Health Benefit Exchange tote bag with promotional items. These brokers go above and beyond to enroll Marylanders in Maryland Health Connection and Maryland Health Connection for Small Business. Next slide, please. Today, I respectfully request your approval to allow MHBE to promote the Broker Achievement Awards for sponsors to help finance the cost. Marketing will be responsible for providing sponsorship packages to organizations who are interested, and all remaining funds after the cost of the Broker Achievement Awards will be allocated to support MHBE's ongoing outreach initiatives that promote consumer engagement and recognize brokers. Additionally, funds will be used to support related programs and activities that advance our goals, such as the Maryland Health Connection for Small Business Expo that we're planning and other awareness campaigns. All sponsorship materials will include a prominent disclaimer stating sponsorship will not confer any special access or benefit upon the donor in their dealings with MHBE or the state. Marketing will also adhere to the gift policy, ensure board approval for donations over $50,000, follow all accounting procedures, and communicate with the CFO and his team regularly, and provide acceptance letters to each donor. Next slide. Each sponsorship will include a level of brand visibility, networking opportunities, extensive coverage on MHBE's social media platforms, and will also create a strong positive impact on MHC's broker community. Next slide, please. I respectfully request your approval to allow MHBE to solicit sponsors by providing a link to the MHBE website and to allow MHBE to post on social media channels. Thank you for your time and your consideration. And are there any questions?
Thank you, Teresa.
You're welcome.
And any questions from folks?
Teresa, when is this event to be held? I think, is it an annual event?
It is an annual event, and in the past, we've had it in May. So this year, we're looking at May the 20th. So we're hoping that between now and the next couple of months, we're able to get some sponsors to look at the different level of sponsorship and support this program so that we can make a deposit and move forward with our items that we need to make it successful.
Well, you and I can talk offline. I may have some ideas about sponsorship.
Thank you.
Thanks, Ken. And he alluded to something I was going to ask. Oh, relatively, this is just an ask to solicit sponsorships, and you'll have like tiered levels as to how people can engage.
That's correct. Yes.
Okay.
And Teresa, I don't know if you mentioned this and I missed it, but we're very grateful to the Maryland Insurance Administration, who was the sponsor for the first 2 years. So really appreciate
That's correct. Yes, thank you to the MIA for your longstanding support. We've really, truly have appreciated over the years. Thank you.
Any other questions? Great. I move to approve the request of the MHBE Marketing Department to solicit sponsorships for the Broker Achievement Awards as presented. Do you have a second?
I can second. This is Kat.
Thanks, Kat. All in favor?
Okay, thank you.
Thanks, Cynthia.
Thank you very much for your time. Thank you.
Thanks, Teresa. And last but not least,
Can I
yes,
jump in for a moment? We have 10
please.
minutes. We have 10 minutes left, and we don't think that's enough time to give the small business portal launch, the
Mhm.
Do It Deserve. So we would request that we bring that back to the board in January.
That's fine. And I was just going to turn it over to Mimi, so we can hold. Great. So I motion to adjourn our meeting earlier. Thank you so much for the time and comments and discussion, everybody, today. And January is our next meeting. So with that, I hope everyone has a great end of the year, Q4, and transition into 2026.
And we likely will have an ad hoc meeting at some point in time. So we'll keep you posted on that.
It's perfect. Thank you for that, Michelle, and thank you, everybody.
Thank you.
Thank you.
Bye.
Have a great day.